Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Welcome to JCO's Cancer Stories, The Art of Oncology, brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the role of cancer care. You can find all of the shows, including this one, at podcast.asco.org. We have a special treat today in our podcast series, in that I had the opportunity to interview Dr. William Breitbart. Dr. Breitbart is the Jimmy Holland Chair of Psycho-Oncology at Memorial Sloan Kettering and the Professor and Vice Chair of the Department of Psychiatry at the Weill Cornell Medical College. And as far as I can see, Dr. Breitbart, you've never left New York City, but I will give some background and you can tell us if you took a vacation or something one time outside the city. Dr. Breitbart grew up in the Lower East Side of Manhattan. He went to Brooklyn College, graduated in 1973, then medical school at the Albert Einstein College of Medicine. And then he did his residency in internal medicine at Bronx Hospital and trained basically at Memorial Sloan Kettering. Joined the faculty there and has been on the faculty ever since. He has a number of accomplishments, too many for me to really review carefully, but he's been president of the International Psycho-Oncology Society and received their Sutherland Lifetime Achievement Award. He's been president of the Academy of Psychosomatic Medicine and received their Hackett Lifetime Achievement Award. And on a personal basis, my brother was also the president of the Academy of Psychosomatic Medicine, so I'm very proud of my brother and equally proud of Dr. Breitbart. He really is responsible for a number of enormous steps forward in our field, including psychotherapeutic approaches for palliative care of patients with terminal illnesses, especially cancer. He has been involved with what I saw you call, Dr. Breitbart, hastened death. I had learned it as assisted suicide. I'm going to ask you questions about that. I'm interested in your comments. And more recently, meaning-centered psychotherapy for the terminally ill, and we'll talk more about that too. So in addition, I have asked Dr. Breitbart if he would also give us insights into Dr. Jimmy Holland's life and her career. Sadly, she's passed away before we had an opportunity to chat with her. She was one of my favorite people in the whole world, and I think everybody who knew her said the same thing. So we'll get some insights for those of you who didn't know Dr. Holland from this call as well. Before we start, Dr. Breitbart wants to declare that he's received honoraria from Novartis and has a consulting or advisory role with Novartis. Dr. Breitbart, welcome to our program today.
Thank you, Dr. Hayes. Pleasure to be here. Can I make just one slight correction? I actually trained in both internal medicine and psychiatry at the Bronx Municipal Hospital, which is the Albert Einstein College of Medicine, New York City Health and Hospitals Corporation public hospital. So I trained in both psychiatry and internal medicine, jumping back and forth between the two out of a state of confusion. And then I landed in Dr. Holland's fellowship at Memorial Sloan Kettering for a variety of reasons. Main reason was that I had developed a thyroid cancer when I was a medical resident in the middle of my training. And then when I went back to finish up more of my psychiatry residency training, I became the liaison to the oncology clinic at Jacobi Hospital, the Bronx Municipal Hospital. I did consultations for cancer patients, and I ran groups for cancer patients, and also ran groups for the oncologists and oncology nurses. And I was trying to educate myself on the subject of psycho-oncology or psychiatric oncology. It actually hadn't had a name yet in those days. And the only literature I could find were papers written in oncology journals by Dr. Jimmy Holland. And so that's where I knew where I needed to go to become more expert in this area. That's the most superficial version of how I ended up at Memorial Sloan Kettering. But I could tell you the more interesting version if you're interested.
Well, actually, what you just covered was my first question. And I was going to say this is about you, not about me, but my brother also did training in internal medicine, decided to go to psychiatry, and ended up in psychiatry liaison. And I think that's what makes you two and others like you powerful, is that if you go to France and you don't speak French, you're not going to be listened to. And if you come to a bunch of oncologists and you don't speak internal medicine and oncology, we're not going to listen to you. And I think clearly to me, Jimmy Holland always knew what I did. And I think you have the same strength. I'd love to hear how you actually got involved with her. Yes, please do.
Right. I agree with you actually about that comment. It's very helpful to have had the training in both medicine and psychiatry. And in fact, we've trained a few fellows who've done oncology fellowships and then done our and psychiatry residencies and then done our psycho-oncology fellowship as well. But the real story of how I ended up in this field starts in childhood, which where a lot of stories start. But my parents were both Holocaust survivors from Eastern Europe, from Poland in particular. When the war broke out, my mother was 14 years old and my father was 17 years old. And my father's family were all killed, but he ended up surviving, hiding in the woods, and he became the Polish forest, and he became a part of a partisan fighter group, lived in the Polish forest. And one day he went looking for food and broke into this farmhouse. As it turned out, my mother and her parents were being hidden by a Catholic woman who hid them in a hole underneath the stove in her barn. And my father broke into this farmhouse and discovered my mother and my maternal grandparents. Turns out they were related. They were second cousins. My father said, "You can't stay here. It's not safe. You should come into the woods with me and 150 other people." My grandparents were too afraid to go, but they let my mother go. So at the tender age of 14 and 17, my parents were hiding in the Polish forest where they lived for about 3 years, hiding from Nazis and then Ukrainians and all sorts of people who were interested in killing Jews. And they finally, after the war, crossed over to Germany. They actually found my grandparents alive, and they crossed over the border to Germany, went to a displaced persons camp outside of Munich and got married there, and then came to the Lower East Side in late 1949, early 1950. And I was born several years later. And I grew up in this home on the Lower East Side, as you pointed out. And I grew up in a home where the Holocaust also lived. I lived in this home where the Holocaust was on in every room, didn't have a room of its own. It was in all the rooms, on all the walls, and all the pictures that had been saved of my family that had perished, on all the religious articles that might have been saved, etc. So I grew up in this environment where I understood at a very early age, maybe 4 or 5 years old, that death and suffering were very real, and that we all lived in this space between life and death. My mother would ask me every morning when she gave me breakfast, she would ask me the question, "Why am I here?" And the full question really was, why am I here and everyone else is dead? Basically, what evolved out of this was the transmission of this responsibility, or I guess a burden, for me was an inspiration. For me to accomplish something of such significance and impact in the world of suffering in particular, in the arena of people who suffer in the face of death, it was going to be up to me to achieve something of such significance that my parents would be able to, my mother would be able to turn around and say, "Well, you see, we had to survive because if I hadn't survived, there wouldn't be Bill Breitbart in the world. And so that was the mission. That was the burden. That was the inspiration. And I wasn't fully cognizant of it, but I was traveling this journey, this route that took me through college and loving science and poetry, ending up in medical school thinking I'd be a psychiatrist, but then falling in love with medicine, loving both psychiatry and medicine. What I realized, what fascinated me was how a human being can live a mortal, finite life. How do you, as a person who develops a life-threatening illness, how do you continue to live? How do you have the strength, the courage to keep on living? And what gives you purpose and meaning? And so I got myself to Sloan Kettering by reading the work of Dr. Jimmy Holland and Dr. Massey, and I found myself at Memorial. I put myself in a place with a mentor, a group of mentors, a place where I would breathe the same air of my patients who were breathing the air of a human being confronting death, confronting the real prospect of death being closer than it was farther away. So that's how I ended up at Memorial. That's the real story. I went to Sloan Kettering to do a fellowship just to become a good clinician. I wanted to be a clinician. I never had the expectation of being a clinical researcher or an academician. I never had the ambition or aspiration to be an academic, a teacher, an advocate. Never hoped to be a professor of anything. I never thought I'd write books or scientific articles or become president of organizations, etc. All that happened because of my exposure to Jimmy. And my interest in research ended up being a result of one conversation that I had as a fellow. Dr. Holland, who was supposed to be my supervisor, she was my inpatient supervisor, my outpatient inpatient supervisor. So we made rounds one day, which was very rare, but we made rounds one day, and I was the liaison. I was very fortunate enough to be the liaison to the neuro-oncology unit and to the pain service at Memorial, which were both within the Department of Neurology. When Dr. Holland was recruited to Memorial Sloan Kettering in 1977, it was by the chair of the Department of Neurology, Dr. Jerry Posner, who recruited both Jimmy to be the chief of the psychiatry service, and he recruited Kathy Foley to be the chief of the pain service. So I basically held on to these two meteors of Jimmy Holland and Kathy Foley. Those are two people who helped pull me along the road. But I was on the neuro-oncology unit. I had done a consult on a patient with a brain tumors on high-dose steroids and who had a severe psychosis. And I asked Dr. Holland, why is it that these patients on steroids develop these neuropsychiatric syndromes? They develop depressions and they can get delirious and psychotic and manic. And this was the advice that my mentor gave me, Dr. Holland gave me, which turned me into a scientist. And her response was, "Well, gee, Bill," in her Texas twang. "Well, gee, Bill, I really don't know. I really don't know. I guess you'll just have to go figure that one out yourself." And that's what I ended up doing. I then pursued figuring it out myself. And that's what I did for the next 30 years, trying to figure out clinical problems. When the AIDS epidemic exploded, my first research study was a study looking at patients with epidural spinal cord compression, those who had high grade versus lower grade compression. One group got high dose steroids, the other didn't. And I did a comparison study of psychiatric syndromes in both populations. I was at Memorial when the AIDS epidemic exploded, and so started to do studies of delirium. I did the first double-blind randomized controlled trial, neuroleptics, for the treatment of delirium in the AIDS population, because they all got demented and delirious. I did the first studies of pain and HIV disease, and I did the first studies of desire for hastened death in patients with advanced AIDS and in patients with advanced cancer. And then started to do a lot more work in inflammation and depression in pancreatic cancer patients. And then eventually everything kind of culminated as I evolved from being a psychiatric oncologist to a psychiatric oncologist and palliative care clinician. That kind of bridged the two worlds of psycho-oncology and palliative care, and started really looking at issues of desire for hastened death and a loss of meaning, and then developed interventions for meaning, which we call meaning-centered psychotherapy, which has been a real advance, I think, in our field.
You must have been Dr. Holland's first trainee at Memorial.
Well, her story was basically, she was this young country girl in Nevada, Texas. She grew up on a farm, a cotton farm, apparently. She was most influenced by the country doctor who would visit when people were ill. And when he passed away, he gave her his set of medical books, which inspired her. And she told her family, I think I want to be a doctor. And they said, well, gee, that sounds unreasonable, Jimmy, but whatever you feel like doing, go ahead. She ended up going to Baylor. And then I think she was one of only 3 women in medical school class at Baylor. She started her residency, I think, at Baylor as well. And then eventually she got married. Her first husband died tragically. I believe it was a suicide, which I think got her interested in psychiatry. She ended up, I think, doing her residency finishing her residency at MGH along with Tom Hackett, people like that. And somewhere along that route, that's where she met James Holland. So James and Jimmy were, as you say, a power couple. James told me that Jimmy was his secret weapon, the secret power. But Jimmy told me the exact same thing about James. I think they fed off each other in terms of creativity and ideas. So when James moved to, was it Roswell Park, I guess, Jimmy started a special clinic. And she called it special because nobody would come to a psychiatry clinic. They would come to a clinic that was special because it made them feel special. And I guess it was around that time that James started collaborators, CALGB. On the drive to work one day, Jimmy said, you ask patients every kind of question, like how many bowel movements did we had? You're very invasive in your questions, but you never ask them how they feel. And so she insisted that, James do something about that. And so in order, I guess, to not get nagged on the car ride every day, he started a quality of life committee at CALGB, and Jimmy chaired that for quite a while. Eventually, I think James went to Mount Sinai and Jimmy came along, and she worked at Albert Einstein College Hospital, Albert Einstein College of Medicine. And she was there with actually a bunch of pioneers of psychosomatic medicine. There was a guy named Herb Weiner and Sig Ackerman and James Strain and Myron Hofer. These are very important names in our field of psychosomatic medicine. Jerry Posner at Memorial Department of Neurology was looking to bring psychiatry into consult service to Sloan Kettering. And Jimmy often says they couldn't get Ned Caston from MGH, so they picked her in second best. And in 1977, she came there along with a resident who graduated from Einstein, Mary Jane Massey, and the two of them had an office with a card table, as she described, and a set of index cards with the patients on it, and they set about starting a consult service. So in 77, she was the chief of the psychiatry service. And then in about 78 or 9, a clinical fellowship was established. The NIMH had an initiative at that point to develop consultational liaison psychosomatic medicine fellowships around the country. And so she benefited from that initiative and started a fellowship that's continued since 78 or so. And there were a couple of classes of fellows before me. I came to do the fellowship in 1984 to 86. And it was during my fellowship, I think, that Jimmy and a woman named Julia Rowland, a psychologist who's at the Smith Center now, but ran the NCI's survivorship program for a long time.
I actually worked with Julia at Georgetown for 5 years.
At Georgetown, exactly. So she and Julia edited the first textbook of psycho-oncology, which is called the Handbook of Psycho-Oncology. And that's the first time I think the term psycho-oncology was used. I think it might have been late 1980s, might have been 1989 or so. the book came out. And the term psycho-oncology was not hyphenated at that point. There was no hyphen between the two O's. Jimmy asked me to write about 6 chapters. I knew a lot about delirium. I wrote that chapter. I knew a lot about suicide and cancer, which was an early interest of mine. And I knew a lot about neuropsychiatric issues and AIDS. But I didn't know very much about the neuroendocrine phenomena that cause neuropsychiatric syndromes or the psychiatric aspects of head and neck cancer. I said to Jimmy, I don't know anything about these subjects, Jimmy. Do you think I'm the person to write this chapter? And she said to me, well, Bill, there are no experts in the world in this field. So after you write the chapter, you will be the expert. And so that was the philosophy. And so as a mentor, I would basically say, the greatest thing about her as a mentor was that she gave you the confidence that you could achieve whatever you want, whatever you were driven to achieve. She had that faith in you. And the idea was that the only person who really had to believe in what you were doing was you. And if it was important to you to find the answer to that question or that you'd be able to do it, she had a knack for finding people who were very driven, who joined this mission. It was really a mission. It was a calling to provide the human side of cancer care, to provide whole person care, to take care of the person who had cancer while they were going through all the cancer treatments and the combination therapies that James Holland's come up with.
2 stories about Jim, who I had more association than with Jimmy, although Jimmy told me the same thing she told you, which is you got to figure out what you want to do, and then you'll be great at it. And
right.
Because I wasn't sure at the time. But with Jim Holland, 2 things. I was a very young guy in the CLGB, and I was named chair of one of the committees, and he was sitting in the back. And I was talking about, well, we need a statistical plan, that sort of thing. And in the back of the room, as only he could do without a microphone, well, Hayes, if you need a statistician, it's probably not worth doing.
Exactly.
And the other is, I once asked him, between you and Dr. Fry, who was my boss, Dr. Fry Reich, the 3 guys, who actually came up with the idea of combination therapy? And I might as well have lit a fuse to a bomb, because he went, well, I did. I was there before they did. They came in, they were under me. I already had, and he sent me the protocol that was dated, so to be sure I understood that he had written it before those guys got there. He was quite a character. And I have to say, your comments about Jimmy and being married to Jim were like oil and water. It's unbelievable to me that they actually had a very loving long-term relationship. She had 5 children with him who are all accomplished in their own right. And
yes, they are.
They just managed to make it work, because he could be hard to deal with, but everybody loved him because of it.
Yeah, I think the secret ingredient there is dedication. They were both people of great dedication and commitment.
Yeah.
And they were committed to 2 things. They were committed to the work they did, and they were committed to each other and their family. And so I think that was the secret ingredient.
There are a number of things in your own career that struck me as I was going through it. That one of my own interest is your work with hastened death. And again, I actually wrote a little sort of term paperish kind of thing on this, and it was called assisted suicide when I read it. I think we're talking about the same thing. Tell us more about that and what you've been involved with and where you think that's going.
Right. Well, my interest in that all started during the AIDS crisis, the AIDS epidemic in the mid-'80s to mid-'90s or so. And I was right in the thick of it in Manhattan, in New York City. And Sloan Kettering had a large population of AIDS patients because of their interest in Posey sarcoma and lymphomas. And we ended up taking care of a lot of patients. And I saw a lot of patients. And I was that age. I was often the age of the patients. Many of the patients who I was treating, it was very difficult work, but very inspiring work. You really felt like you were doing important work, obviously. And because many of the patients were younger men, men in their 30s who I could relate to in many ways, like you, I'm sure there are many patients that you treat. There are some that you feel closer to, you identify a lot more with, right? And that was the case here. And at the time, I was treating patients with AIDS, and there was no therapy at all, and people were dying very difficult deaths. And I had many, many patients who would ask me if I could help them die, if I could assist them in their suicide. Could I prescribe them medicines? Could I somehow hasten their death? And so for me, it was a clinical problem. What do I do? How do I understand this? What drives this desire to hasten your death? I knew it came out of a sense of despair. I knew it came out of a distress and a sense of despair. But at the time that this was happening, clinically, there was also a big debate in our society about legalization of assisted suicide. And in fact, I think there was the Supreme Court case of Vacco versus Quill, right, which was also being adjudicated at that time. And states like Oregon were starting to have referendum about whether to legalize these things. So I thought, does one create policies based on popular opinion or whatever, or public opinion? Or do you create policies that by understanding the problem and doing, that's informed by research? So I thought I needed to understand this. If I was going to be helpful as a psychiatrist, right, in this kind of a setting, and it came up occasionally with cancer patients too, but it was just so dramatic, and it confronted me for the first time, mainly during the AIDS crisis. I felt I needed to understand it more so that I could know how to be helpful or useful. Was I going to be able to eliminate the suffering, or was my only option to eliminate the sufferer, right? And so we set about doing a set of studies both in terminally ill AIDS patients and terminally ill cancer patients. And I actually developed and validated a scale that measured desire for hastened death. It's called the Schedule of Attitudes Towards Hastened Death. Up until that point, people didn't really have a way of measuring it. They just ask a patient, yes or no, do you have, or they might quantify it on a 0 to 4 scale or something. And so what was really interesting, and one of my early fellows, my first fellow, the first year I was attending, was a fellow named Harvey Chochnov, who went back to Canada, Winnipeg, and he started to do studies. We did studies around the same time, but he didn't have a validated measure. But we ended up finding very similar things. As it turned out, about 40%, 45% of folks who had high desire for hastened death had a depression, right? About 17% of patients of cancer, we'll stick to the cancer data, about 17% of cancer patients have a high desire for haste. These are patients with advanced cancer in a palliative care unit or a hospice unit, whatever. And about 45% of those patients had a depression that was undiagnosed, untreated. The other factors that seem to contribute to desire for hastened death were things like lack of social support, uncontrolled pain, and severe physical debilitation. So I said, well, we can treat pain, we can increase social support. I gave a presentation one day. Kathy Foley had worked with George Soros and the Open Society Institute to develop something called Project on Death in America. And I gave a talk to the board of the Project on Death in America. I was one in the class of the first faculty scholars of Project on Death in America. It included a lot of people who are at the forefront of palliative care these days. But I gave a talk on desire for hastened death, and one of the ethicists in the room, famous ethicist from Einstein, asked me, "Well, what happens to desire for hastened death if you treat the depression?" And before answering that question, I said to myself, make a mental note. That's your next R01 grant, Bill. And so what I did after that is I wrote several grants, did 2 studies looking at treating depression in patients with high desire for hastened death. And I did both in AIDS and cancer patients, terminal cancer patients, 2 different studies. And as it turns out, if someone has high desire for hastened death and they have a depression and you treat their depression, 90% of those patients, when the depression remits, the desire for hastened death remits. But there was still this segment of population of advanced cancer patients who were not depressed, did not have uncontrolled pain or lack of social support. Things. There was about a 40%, 40% of the group. I didn't have any element, a factor that contributed to this desire for hastened death. So I figured there's something there that I haven't found. So we went back I did further studies, and we looked at other variables like anxiety, hopelessness, loss of meaning. And what we discovered was that both hopelessness and loss of meaning were independent and synergistic factors that contributed to the desire for haste and death and made up an additional 30% of the so-called variance. So between depression and hopelessness, independent of depression, and loss of meaning, independent of depression, you could account for about 85, 90% of the reasons why patients want a desire for haste and death. Based on my research and the research of others, there's still about a 10% group who are probably not in great despair, but the issue for them is I lived my life in a free, authentic way. I've been able to control how I live my life. I should be able to, and I want to control the circumstances of my death, right? And they're not impaired by depression or anything like that. But when we had the findings of hopelessness and loss of meaning, I said to myself, okay, now I've got to find an intervention for loss of meaning and hopelessness. And I was looking for a drug. I went through every page of the PBR, and there was no drug for loss of meaning or loss of hope. So I had to turn to psychotherapy. A CL psychiatrist, we have psychosomatic medicine psychiatrists, we like to give drugs, If there's a drug solution, we got it. I'm your guy. But so I had to force myself to turn towards psychotherapy rather later in my career, after doing all of these stimulant trials for fatigue and things like that, other pharmacological trials for pain, neuropathic pain, etc. There are delirium trials. There I was starting to figure out what kind of psychotherapy can I develop to help enhance the sense of meaning and hope. And that's when I turned to, ironically, a Holocaust survivor named Viktor Frankl, and turned to the work of Viktor Frankl, who wrote the book Man's Search for Meaning. His big idea was that meaning is a primary motivating force of human behavior, similar to the idea of libido, an instinctual drive, and things like that. He thought meaning was another important drive, meta-instinctual, he called it. And he thought that there were predictable sources of meaning that one could tap into. And so we basically developed, just sat down in a room with a couple of my fellows, and we hacked out actually at the beginning it was a group intervention, so it was an 8-session intervention. And then we developed an individual format, 7 sessions. And we basically developed this brief structured psychotherapy that involved teaching patients the importance of meaning, both didactically and experientially, teaching them the various sources of meaning and relating it to their cancer experience and living with cancer. And the whole purpose was to be able to get through cancer and even facing death by sustaining a sense of meaning for as long as you possibly could. And that's what we called meaning-centered psychotherapy. I ended up doing 4 randomized, NIH-funded randomized controlled trials of both individual and group format. And now we're in the 7th year of an R25 training grant. We're training a national and international cohort of clinicians to provide meaning-centered psychotherapy, and the manuals and textbooks published. I designated it as a evidence-based intervention for palliative care.
Well, I'd like to segue that as you were talking. Most of the people listening to this are probably medical oncologists.
Yeah.
And my impression is we don't get a lot of this training that you're talking about. And the people you're training are probably psychiatrists, not medical oncologists. How have you translated that over to our world?
Yeah, so actually the people we're training, a few psychiatrists, not too many. We're training psychiatrists, social workers, nurse practitioners, oncology nurse practitioners, oncology nurses, oncologists, chaplains, palliative care docs. We're expanding the training, and it's quite simple. And it's actually, we're working with a group to sort of develop this into a digital app. Might be able to be prescribed by oncologists, so that you don't even need a therapist.
Are you in the weeds with the medical oncologists at Memorial, the fellows? I mean, do you make rounds with them and help train them?
Yeah, Jimmy started out with one psychiatrist. By the time the psychiatry service became a department in 1996, I think there were 12 psychiatrists and psychologists. And as of last count, I think we have 43 faculty, 25 psychiatrists, and the rest psychologists, and around 200 staff, including research staff and research faculty, and psychiatry service, which I took over as chief when Jimmy became the first chair, and a behavioral sciences service, and we have a cancer disparities and immigrant health service. So it's grown quite a bit. And all of us, we work on a sort of a disease management embedded model. So I originally was the psychiatrist for the neuro-oncology and pain service. So I moved to the hepatopancreatobiliary disease management team. But all of my psychiatrists and psychologists are embedded in the breast center and in the GI group, hepatobiliary pancreatic groups, and head and neck and thoracic and all that. So we're all interacting there. And
how do you translate that outside of Memorial in New York? I mean, most oncologists don't have access to this kinds of resources.
Yeah.
You've got to have thought about that.
About 1996, the National Cancer Center Network, the NCCN, got established and started developing guidelines, right? And so they asked Jimmy to head up a guidelines for distress. And I was part of that group and still am. And what came out of that was screening for distress using a distress screening tool.
The distress thermometer. The distress
thermometer.
I remember she showed it.
Exactly right. And that came out of the pain work, right? The pain guys had their 0 to 10 scale. We didn't want to rip them off too badly, so we didn't want to do the 0 to 10 visual analog scale, so we had to come up with a different metaphor, so we call it pain thermometer. So this distress screening Commission on Cancer, I think, that accredits cancer centers through is it the Academy of Surgical Oncology or something like that. They mandated that for a cancer center to get accredited, you have to have a distress screening program. And if you have a distress screening program, then you have to have people who respond to these algorithms that get developed for people who get identified with high distress. So as a result of this, that one move of establishing, distress as the sixth vital sign, which was Jimmy's idea, and developing distress screening, you now have every NCI designated cancer center has to have a psycho-oncology program of some sort. Now, a lot of them aren't as big as ours. Some of them basically involve a half-time psychiatrist, a chaplain, two psych nurse practitioner, and a couple of social workers. But every cancer center has psycho-oncology present in it now as a result of that.
I was having dinner one time with Jim and Jimmy, and she said, "You two know the blood pressure, the temperature, the weight, pulse, but you have no idea." As you said, how do they feel? So
right.
It wasn't the last time she asked Jim Holland that question. And I went, "What do you mean?" She goes, "You need a stress thermometer." She'd already published it. Of course, I didn't know that.
Right.
And pulled it out of her purse and showed me a picture of the stress thermometer.
That's correct. That's correct. One of the big problems is when Jimmy started, and you can attest to this, with in the beginnings of oncology, it wasn't always the case that patients were told exactly what they had. Right? Cancer was very stigmatized. The only thing that's more stigmatized than an illness like cancer is mental health. Right? God forbid you should have a problem with depression or coping or panic or something like that.
Sign of weakness.
A weakness, moral weakness. Thankfully, we've come a long way in terms of truth telling and being transparent. And my patients now know exactly that all the genetic mutations of their tumor and stuff like that. They know everything, and they even know how their tumors mutations are evolving and changing over time. But cancer, with the idea of needing psychosocial counseling, psychiatric help, psychological help, that was very stigmatized. So even the word distress was chosen out of a concern to not stigmatize patients.
I will tell you that when I was at the Dana-Farber and there was a push for the Dana-Farber to develop its own hospice program. And Dr. Fry, who was physician-in-chief, absolutely drew a line and said, no way, because that means we've given up on those patients. We're not going to have a hospice program at Dana-Farber because we don't want patients to think they're coming here to die. And I remember thinking, but some of them do. And, it would be very helpful if we had a way to help them figure it out. And I have to say, in preparing for this podcast, I read several of your papers and thought, God, I wish he'd been at the Dana-Farber when I was there, or I wish I'd been at Memorial to get to work with you. Where you can see I'm kind of tying things up here because I could listen to you for hours, but we only have 20 or 30 minutes, and this has been terrific.
I appreciate the opportunity.
I'm sure our listeners will say, maybe wonder how we can get him to come speak to our program somewhere. I already wrote down here, we're going to invite you to Michigan.
In this era of Zoom, I'm a very cheap date because all you have to do is just, connect me by Zoom. You don't have to pay for the airfare or anything. I go everywhere.
I want to thank you for lots of reasons. One is for filling our listeners in, many of whom are young, about who Dr. Holland was and what she did, because we all owe her an enormous debt of gratitude for what the contributions she made, and you personally as well. So thank you for taking your time to speak with us, and we really appreciate it. And I hope our paths cross again in the near future. Thanks a lot.
Absolutely.
Dr.
Thank you so much. It was my pleasure. Appreciate it.
Until next time, thank you for listening to this JCO's Cancer Stories, The Art of Oncology podcast. If you enjoyed what you heard today, don't forget to give us a rating or review on Apple Podcasts or wherever you listen. While you're there, be sure to subscribe so you never miss an episode. JCO's Cancer Stories, The Art of Oncology podcast is just one of ASCO's many podcasts. You can find all the shows at podcast.asco.org.